It's my pleasure to invite up Dr. Bryan Sisk, who is an assistant professor of pediatrics and pediatric hematology oncology at St. Louis Children's Hospital and part of their vascular lesions clinic. So interesting talk to come from Dr. Sisk also.
Hey, look at that. Thank you. So can everybody hear me? All right, I'm just gonna start my timer so I don't go way over. So I am really excited to be here talking with everybody today. I'm gonna talk about care delivery communication experiences. And I have no conflicts of interest. I just want to say much of this work has been with other colleagues and collaborators like Anna Kerr and Sally Cohen-Cutler. And I also want to say that, let me see if I can move this. I also want to say that this is a daunting task because I am coming to talk to all of you who are experts in what your experiences have been. I'm an expert in treating patients and in doing research, but I learned from you guys what's going on in your lives, and I'm trying to synthesize it and give it back to you. So I'm coming out from under the desk to do this, and my goals today are really to help with solidarity for anybody that's newer to this group or that's newer to finding their diagnosis or finding out what's been going on with their body, to make sure you know that you're not alone, that other people have been sharing similar experiences. I want to give back. Whenever we do research, we ask so much of our participants. We ask so much to give us your stories, to give us your time. And I think it's really important to make sure that you know what we're doing with it and why we're doing it. And then I want to leave some time at the end to really think about what's next, because I think the worst research you can do is where, as the researcher, you pick the problem that's important, but the patients and the caretakers say that doesn't really matter to us. That's a lot of wasted energy and wasted effort. So with that, I also feel like I need to tell a little bit of the story of why I study these things and how I got to it, because I think that matters as well. So we're going to talk a little bit about my prior work focused on cancer, how I think some of it might apply in this realm, talk about why I switched to vascular anomalies and what I discovered when I got there, and then think about, based on the data I'm going to show you guys, what we might do in the future. So I'm going to summarize about 5 years of work in 2 slides. So that's not going to boost my ego, but that's okay. So I studied communication and care delivery, and a lot of this work started in pediatric cancer. And our first question was just, we all talk about communication, and what does communication mean? What are we actually achieving? And so through a bunch of work with patients and parents and clinicians, we identified this functional model of 8 core functions that we're actually trying to achieve when we communicate. And that includes things like exchanging information, helping families to manage the care at home, managing uncertainty, but also really important things like providing validation, making sure people know that we respect and appreciate their insights, that their concerns matter, that they're an empowered part of the team, and then also supporting hope and figuring out what hope means for each individual family and each individual patient. So that was 2.5 years of work. Next. So then we really wanted to know, this is what communication is supposed to do, but the next logical question is, what gets in the way that prevents us from communicating? And the easy answer is, well, somebody decides not to communicate well. And I'm a doctor, but I've also met doctors that sometimes are not great communicators. And so there's certainly the individual component of somebody that either doesn't have skills or doesn't have the interest to try to communicate. But my hypothesis was that that's only one of really multiple levels of factors that influence how we communicate. And so again, through a big review of the literature and through focus groups with patients, parents, and clinicians, we identified actually 7 different categories of factors that influence how we communicate and how we interact with patients. And it's things like individual characteristics, the clinical characteristics of the patient. If you've got a cancer that's never been cured, that's going to influence the way you communicate. How well is the team communicating? What's the structure within the hospital? But also things like policy, even things like community. What's the image of the hospital in the community? What type of past abuses, past biases are influencing all that? So it's a really big, complex web beyond just, does somebody want to try to communicate well or not? So that was another year. The next slide is, then we said, logically, we know what communication should accomplish. We know sometimes it doesn't accomplish that. What can clinicians do when communication fails? and what happens when communication fails. And so we found that when parents and adult patients were reporting that communication really didn't work out, there was a variety of harms, of things you would imagine, like lack of understanding or lack of information, frustration, distress. But there are also things like financial harm, medical harm, getting procedures done where you didn't need a procedure. You're starting to hear some trends that might be translating into your world. And so what we developed with families was a process that we might encourage clinicians to do when there is a negative experience that parents or patients are experiencing. So if you see a patient or a parent who seems to be frustrated, seems to be angry, but also importantly, seems to be a more and more persistent advocate for themselves, that can be a sign that something's not going wrong and there's a reason why they feel like they need to advocate more and more strongly, trying to get a sense of, there's something I don't understand what's going on. Let me ask them what's going on. So exploring, trying to understand what's driving the situation, what's affecting you, acknowledging once the family tells you what's going on, that sucks, I'm sorry that happened. Informing, but the important thing with informing is asking the family if it's the time that they want to hear the information, because often we are on a busy schedule and we view our job as giving information, and it's not always the right time to give that information. Adapting the way that you're giving care to make sure that you're addressing the issue that caused that negative experience, and then promising to advocate so that it doesn't happen to that patient or other families. All right, that was the last year. And then I finished all of my training and I went into my career as a clinician. I went and finished my hematology and oncology training, and I had to figure out what I was going to do. And what happens for a lot of people that get in this field as a clinician is it's just dumb luck and chance. There was a need at my institution. I had a couple of patients through my training that were really meant a lot to me, and it made a perfect sense to switch from focusing on cancer to focusing my clinical world on vascular anomalies. So as Dr. Adams would say, I became a vascular anomalist. And very quickly, I knew I was coming into vascular anomalies with this training in communication and in care delivery and social sciences research and ethics. And so I had this natural antenna up when I was talking with families, and I started noticing things repeatedly, like families telling me about how hard it was to find a doctor that had heard of their disorder or their syndrome. The number of families that just started crying because I had heard of that. The harms of having an incorrect diagnosis that leads to incorrect treatments. The challenges of finding high quality information. I know I'm seeing head nods. I know I'm not telling you anything new. But this was something that I thought this really triggers a lot of my researchers' mind to say, I wonder how widespread this is and what we know about this. So I got connected with another researcher named Dr. Kerr at Ohio University. And we decided to do a literature review. My approach to any research question is, I'm not smart enough to know the answers. I need to look through all the literature there is and see what answers we know through there. And when I did a lit review looking at communication experiences, I found 4 articles. To give a little context, it related to vascular anomalies. To give context, that same year, I did a systematic review looking at communication studies in pediatric cancer over 3 years, and I found almost 100 articles. So this is all time ever. We were able to find 4, maybe 5 articles if we stretched. When I then looked to see, I wonder what we know about how families and patients actually access care, how that care is delivered, what the effects of the disease or the syndrome are on them. I just kept coming up with not a lot. And in a research world, that provides really good opportunities and challenges. The opportunity is that there's so much we can do to try to understand and try to fix problems. The challenge is you have to be able to prove there's a problem on paper to get people to give you money and try to fix it. And so that's where we said, we don't want to jump to we're going to fix things right away, because we first need to know what gets in the way of getting effective care. How frequently is that experienced? So then we can be smart about which problem we try to target, which bite we try to chew first. And so that's where I'm going to talk about today. And again, it doesn't sound that exciting, but documentation of things we already know on a personal level is super, super important, because if we can't convince the people that have the funding that this matters, we're not going to get the investment to fix the problems. And so I reached out to a bunch of organizations, especially the first ones were KT Support Group and Cloves. And I came with my hat in hand and said, I am a lowly new doctor studying this. Here's my vision. Can you believe in me and invest? And I was really, really fortunate that I ran into Melanie Finger and she believed in me. And so we had this first project, which is still ongoing. We had really three aims. One was to understand through an interview process, what are the experiences of care delivery, communication, all the things we were talking about, both for parents or caregivers or caretakers of minor patients, and then for adults with these disorders as well. And then the second aim is to say, how do we then quantify that with a big survey? We'll come back to that a little bit later. That's still ongoing. And then the third is, what about patients that are in their older age that have been dealing with this for a longer time? Because a lot of the people that I spoke with said, I really am uncertain and curious about what happens in the future. And so we have another project where we've talked with adults who are older than 65 years old to get their stories as well. Today, for time limitations, I'm just going to focus on the first one here, and I'm just going to focus on one or two of the early analyses. And again, I'm probably not telling you anything you don't know, but I'm hopefully structuring it in a way that's easier for us to explain to others. Our research question was, what are the factors that influence your all's ability to find doctors and medical teams that know how to care for you? That was really the simple question. And what we found through all of our interviews is there's really 6 categories of factors that we'll go through that seem to interact and influence whether you're both gonna initially find a doctor and a medical team that knows what to do and maintain that care. And both of those were challenges for different families. And then we'll talk a little bit about the role of information in all of these different factors. So first, individual characteristics. And this broke down into characteristics of the clinicians themselves. And I'm gonna talk about all of these in positive lenses, but they were not all told to me in positive lenses. So some of these might be reflecting an absence of this characteristic. When clinicians are knowledgeable, when they are committed and responsive and available, and a lot of people mentioned the humility of admitting when you don't know something, especially when lack of that admittance leads to harms. And just to reflect some quotes back to you, I hate to say it, but there's a level of arrogance with some doctors. They don't want to manage things from another doctor, and it's hard. It's hard getting people to play nicely in the pool sometimes. Then there's patient and parent characteristics. Being knowledgeable, being persistent, being an advocate for yourself. These interviews were dripping with advocacy of patients and parents and caregivers who are doing any and everything, running through every wall they can to try to get the answers that they need. And now I'm going to move this again. So out of desperation, I just felt relentless that I had to keep advocating and finding different avenues whenever we did find providers who wouldn't help us or who didn't know what to do. Finding the walls, pushing through them, going under them, climbing over them. And I know there's a way to make this disappear, but I'm just going to move it there for now. There were clinical characteristics of just what the disease or disorder presentation is. So depending, whether you get an accurate diagnosis, how quickly you get an accurate diagnosis really matters. If you have a diagnosis that isn't correct and it leads to treatments that aren't correct, that can be really harmful. And sometimes you just can't find the information that you need. And so this participant said, it's hard to describe how helpless you feel when you don't know what it is because you have no path forward. There are certain characteristics of different presentations that make it easier to get to at least get attention, I should say. So for example, patients that had a harder time getting a diagnosis were ones where it was fully an internal vascular malformation. And it didn't have really obvious skin findings because it was harder to get people to pay attention because you couldn't see it. Patients that had very severe presentation, they got a lot of attention earlier because they were very sick. It doesn't mean they got a diagnosis, but they got attention. For example, it just started to grow very rapidly and it became debilitating rapidly and it was like wildfire. So not that you would sign up for this, but that is something that got some of these patients medical attention more quickly. Scientific progress. This is not news to you either, that we would love there to be more advancements in the way that in the tools that we have to take care of these, both to understand what's going on with these disorders and to treat them. And so there's the limited evidence-based treatment. I don't feel like we're ever going to make real progress because there's just not enough money behind it, and there's not enough motivation to fix this. There's something here that does feel very hopeless at times. When you have a condition that's not fatal, the motivation for research doesn't feel there. From the research side, I know a lot of dedicated researchers that feel very differently than this and very, very motivated. But it's not everybody. And I totally take to heart that we need to figure out how to raise awareness, like Dr. Adams was saying, how to raise motivation and get investment from philanthropists, from federal government, et cetera. There's a double-edged sword of this, though. When you are a parent, a caregiver, a patient with a rare disease, you feel an onus and a requirement or a duty to be part of these studies, but they can also be taxing. And so this person said there's this responsibility when you have an ultra rare disease to be the guinea pig, and there's a benefit for being that guinea pig, and you want to be that guinea pig, but sometimes you don't want to be the guinea pig. And so there's this real tension that I heard from a lot of families, that wanting to do what's right for yourself, wanting to do what's right for others, and sometimes those are in conflict. Believe it or not, there are social network things. I'm not sure if you heard of any of these patient advocacy groups. So social networks played a big role. And so patient advocacy groups, I think, the first person support, the camaraderie, and knowing you're not alone. Even if you've not had the exact similar situation, you can find people like you, people that can give you some guidance on what to do. Just like everything, there's double-edged swords. And sometimes with social media, sometimes with these advocacy groups, a lot of people express how you have to take it with a grain of salt and know what applies to you and what doesn't. So, there's definitely things about groups that have made me uncomfortable. There's some, you have to go to this one doctor who's going to do this one thing outside of ordinary, and that's the person you have to. And this person said they take a step back from those sorts of situations. So it's just an acknowledgement that with every great tool, you have to be careful to make sure it applies to you and your life correctly. This is the one that struck me so much, is how much of finding access to the right doctors is just privilege, luck, and just dumb chance. So do you have financial security? Did you happen to bump into the one doctor who read a paper or who had a patient before that had something like this, or who heard somebody say something, in the doctor's lounge that said, oh, I've heard of that disorder? Did you happen to, bump into a doctor at a conference that said, I think this is what's going on? Did you happen to be born close to one of these centers? These things that you have no control over, but can influence whether you're able to get to care. And to summarize it all, this person said, I recognize that we are really, really fortunate that we have the ability to go across the country and do this. We have the ability, but not everybody does. And that's really important. And then lastly, the healthcare system. And this includes, are there multidisciplinary teams? Are there specialists? When there are, can you get into them? We know the challenges that for us to do a really good job with a multidisciplinary team, we need to know as much clinical information as we can ahead of time. But that means that we're relying on patients and families to get all that information together. And some of the families I talked to said this is like a full-time job just trying to get into this multidisciplinary clinic. And in fact, some people quit their full-time job just to be a caregiver and help pay their child to get into this care. And then we all know there's insurance challenges, especially when you're crossing state lines. There's financial challenges. And then just if you're in remote areas, especially, whatever local resources are available nearby. And you can sense some of the desperation in some of these responses. It's just not knowing how to navigate these systems, or who to call, or how to talk to a doctor, or how to pass information on, and just trying to understand how the whole system works, and managing the clinical team's expectations can be overwhelming. And I suspect there's many people here that could tell me more about that. So I want to take a step back as we're talking about healthcare systems to just briefly talk about another study that we're doing right now, and we hope to publish soon. This is with Sally Cohen-Cutler. When we think about vascular anomalies and resources, we have to think about, where can we send these families? Where can we send these patients? And we don't know yet. We've got some idea, but we don't really know. So we did a project where we scoped out every children's hospital we could find in the country. We looked at all of their websites, called all of their phone trees to, as though we were a patient or family, saying, who here actually cares for patients with vascular anomalies? Then finding out how many of them have multidisciplinary teams. and then trying to understand that data so we know what resources we have. And there were 200 hospitals. About 145 of them had some indication that they had a doctor or a team that could take care of vascular anomalies. And then about 94 of those 145 agreed to do the survey. And so I'm just going to show you two pictures. This is all of the different children's hospitals in the country. And it's a heat map as well. So like in New York, there's 20 hospitals in this one little area. In Montana, there's one hospital in this whole area that calls himself at least a children's hospital. So keep this picture in mind. And then the next picture is going to be where we have multidisciplinary vascular anomalies teams. There's a pretty big difference. And just to highlight that difference, I drew some circles here. These are areas, I think it ends up being 13 states where we couldn't find any multidisciplinary teams that were advertised or that hospitals were aware of. And this doesn't mean that every multidisciplinary team has multidisciplinary expertise. It means that they have a team. So there's a lot of challenges that we're still sorting through of how do we make sure we know what resources are around and where to send folks. And then information plays a big role across all of these. So parents and patients advocate. Seeking information came across as a means of advocating. Knowing what's going on and finding whatever up-to-date information you can be a form of advocacy in itself. But it's hard to find information about disease. It's hard to find information like we found in that study of where you can go as a patient or a parent. There's limited information. We talked to some parents in patients where it was a rare presentation of an already rare disease. And that becomes even more challenging because you might find somebody that's heard of the more common version of that, but it might not all apply to you, or you might not know, is there a category I fall into or not? That's where information is lacking. Social media, though, has been a really important repository of information, both scientific information, but from my experience with patients too, is I learned from patients about rare symptoms and side effects because they're talking to a bunch of people on social media. And so we take that really seriously when somebody says, well, I talked to 7 other people on my Facebook group that said they did have high cholesterol, not just high triglycerides on sirolimus. There's things like that that we learn about early because we talk to these patients who use social networks. And then we talked about scientific progress, and then luck and privilege of, do you happen to have access to where you can get past paywalls to actually read articles? And the reason this all really matters to me, especially when I think about this is, if you were to say, design the perfect recipe to create disparities, take something that requires immense amounts of advocacy, financial resources, and luck, like that's the perfect recipe to say, how do you make it so that it's hard for people, especially people with limited means, who were born in the wrong area, who don't have the capacity to advocate because of whatever reasons. You make it really hard to get that expert care. But I don't want to just point out all of the problems. I also want to look at some advice and some things that we learn from families, both advice to other patients and advice to clinicians. And so first, this is, again, these are things you all know, but things that I think it's important to spread out so that other clinicians can learn them too. We asked about advice that parents and adult patients would tell clinicians. And they really clustered around these communication functions we talked about at the beginning. So advice about how to build a relationship. So showing care and concern, showing commitment, empowering and validating came through in just about every interview. Being clear in the information you give, but also recognizing the emotional burden and the emotional toll. There's a number of people I've spoken with that said until a certain point, they had never had a doctor that acknowledged the emotional burden of having a disorder like this. And then lastly, thinking about managing uncertainty and acknowledging your limitations, acknowledging the limitations of the field, guessing when it's appropriate, but trying to adapt how you manage uncertainty and how you balance that with hope based on that individual relationship with that patient. And then lastly, again, nothing that you don't know, but something that I think it's important to remember is advice to other families. Being an advocate, advocate for yourself, be a pain in the butt. Address your own mental and emotional well-being. We had some participants that said, even for me, I really focus on particular symptoms, particular physical manifestations, but I don't take enough time to focus on my mental health and well-being. Finding social support, doing what you're doing right here, and then promoting your self-management and your self-care. And so we've got a bunch of other analyses on this data. So we're looking at what the role is of the primary care clinicians, both currently, and then what is the ideal from different persons' perspectives. How we access emergency care, what happens when patients access emergency care, how we can potentially make that better, what the burden is of having these disorders and disease on patients and caregivers and families. Again, it's important to document what it's doing and how it's affecting lives so that we know how we might measure if we're improving and target to improve these things. And then my personal hobby horse, we're going to be looking at the communication function framework and trying to apply that to vascular anomalies. Quickly, I will say that second aim, we are still doing the survey. So if you are an adult with a vascular anomalies of any sort, or if you are the patient or caregiver of someone with a vascular anomaly, you are more than welcome. There's a QR code, there's a website, there's my email address, and I've got flyers if anybody's interested. There's no obligation to do this. It's totally anonymous, totally voluntary, but there is a $25 gift card for people that live in the US. It is open to international participants though, so all comers, but we can only give gift cards within the US because of IRS rules. And I'm not intentionally dwelling on this. And then this is where I just want to say, we're trying to think now, what's next? What are we going to do next? And the topics that seem to be coming to mind that require more digging is, what do we do about emergency care? I've heard so many tough stories of people that go to the emergency department and they're not validated, they're not believed. How do we build tools with the tools that we currently have, or building new tools to make that better? What do we do for primary care? Is there a better way that we can do it than we're doing it now? How do we address these information needs? Also disparities. It's really hard to prove that you're not diagnosing things in people, but there's ways to go about it. And I'm really worried that there are huge swaths of the country, both rural versus urban, racial, socioeconomic. I'm really concerned that there's big disparities in who is able to get to doctors who know how to take care of them. And then I think a next subset is who's getting genetic testing, as you saw with Dr. Adams, and you'll see later how important genetic testing is becoming in how we understand these disorders. I'm also interested, I have too many interests, but I'm also really interested in transitions. We know that there are not a lot of adult providers that are going to take care of our adult patients. So how do we either A, build up that infrastructure, and B, how do you transition to kind of self-ownership of care when you don't have an adult provider? It's a really important and interesting challenge that I think we can engage with our communities to try to understand better. And then once we learn this for KT and for CLOVES and for PROS, how do we figure out what lessons we can then adapt to other rare diseases so that we can lift all those? And with that, let's see, acknowledgements. So there it is. Thank you. I'm sure there are people here that have been part of this research. None of this would be possible if it wasn't for you. I'm really grateful. I hope this is the beginning of a long, ongoing relationship. So thank you all. And then I do want to thank all these other people that helped me too.